The addition of mutational analysis at the time of diagnosis in acute myeloid leukemia adds cost to the care of these patients and may actually even delay therapy if you're considering acting upon it. Until recently, the major benefit of having this information was prognostication. Based on this, the College of American Pathologists and American Society of Hematology put out guidelines in March of 2017 strongly recommending FLT3 ITD mutation analysis at the time of diagnosis. I believe the reason for this is mostly around the prognostic significance of that information. However, we now have a drug that is approved for patients with both FLT3 ITD and TKD mutated disease, midostaurin. And so I think this actually should be broadened to a strong recommendation for FLT3 mutational analysis at the time of initial diagnosis. All other mutational analysis will add prognostic information and is not needed as quickly as the FLT3 analysis is, at least at the time of initial presentation. There's much debate in the literature as to how all of these mutations may interact, and things that we don't yet have standardized, such as the relationship between allelic ratios and allelic frequencies of FLT3 and ultimate outcome, and how the different genetic changes may interact in a patient. And so there still is quite a bit of uncertainty of specifically how we can use this information to improve on the prognosis, to act on those markers to better the outcome of these patients. But based on the fact that it is prognostically important, and we've been using these features to generally consider patients for allogeneic stem cell transplantation in first remission if they have high-risk features, and now that we have an FDA-approved drug for the FLT3 mutated patients, I think there should be quite a bit of emphasis on having this done for all patients with acute myeloid leukemia. And specifically, I will reiterate that the FLT3 PCR test should be ordered at the time of diagnosis, because this analysis will be resulted quicker than a next-generation sequencing panel, and NGS panels may in fact miss the presence of a FLT3 ITD mutation based on the technology that is used.
In the community, I think that now there is sufficient data to say that the FLT3 inhibitors are no longer in the research arena, and these are either approved or some of them are close to approval. In the lectures and in the recommendations we give to a lot of our community doctors, we recommend checking for many mutations in newly diagnosed AML, but the most important of those are FLT3, IDH1 and 2, TP53, and NPM1. And indeed, the NCCN guidelines as well as the ELN guidelines now routinely recommend checking for these mutations, and almost all insurance carriers that I'm aware of actually cover testing for these mutations. So we think that this mutational testing should be done, but not only should it be done, it should be done very quickly, because now we actually have treatments that can impact the outcome, so we need to have these results in real time. There are a number of labs that are doing these testing and are able to give a quick turnaround. One of the things we've learned is often the physician or his staff, the PAs, nurses, have to call the send-out lab, whether it's Foundation Medicine, Neogenomics, there's a lot of them. And if you call and say, look, I'm considering this patient for a FLT3 inhibitor, I need to have the results in 7-8 days, almost all the labs actually are able to act on it and give the results. However, if you just send out a standard panel, often they think this may be for the subsequent relapse, or this may be more just as a research, didactic activity, and they may take up to 14 to 20 days. So I think this is a very important point for community doctors, that you need to call and get the FLT3, IDH, NPM1 mutation testing. Now, if you have a patient who has a very high white count or who has very proliferative disease, one should already be thinking that there is a higher chance that this will be a FLT3 mutated patient, because this is how they present. So especially in that setting, I think it does make sense to try and wait. I get a lot of questions about waiting. You know, for the last 30, 40 years, there's been a dogma that AML is acute, severe, emergency, the sun should not set on AML, you have to do chemo. And I think if you speak to almost all the experts across the country, we've actually changed our mind on this. So we do think that earlier treatment is good, but the benefit of adding targeted therapy is more. So if one had to choose whether you're going to add a FLT3 inhibitor or an IDH inhibitor or Mylotarg in the appropriate settings versus just treating quickly and not adding those, there's a lot of data to show that the addition of the appropriate agent actually gives you more bang for the buck and is more important. Now that being said, we're not saying you can wait on every single AML, because I don't think all AMLs come in one flavor. So if you get a patient with a white count of 120,000, 130,000, and he's unstable and he has hypoxia or shortness of breath and he has fevers, you have to go ahead and start the treatment. You can still send off the testing even on peripheral blood, and when you get the results back on day 7 or 8, you can add the FLT3 inhibitor in that situation. So I think whether you can wait or whether you start and get the testing, the key is to get the testing done. And I think that's what we're really recommending in the frontline setting for FLT3 mutation.
From a purely clinical standpoint, the only mutational analysis that must be repeated at the time of relapse would be mutational analysis for IDH1 and IDH2. And the reason for that is we now have 2 FDA-approved drugs for the IDH1 mutated patients, ivosidenib for the IDH2 mutated patients, and axitinib. Outside of those therapeutic targets, there are no approved drugs for patients with relapsed refractory acute myeloid leukemia. Now, on the other hand, since the outcomes of these patients with relapsed refractory AML are so dismal, that my feeling, especially practicing in an academic environment, is that these patients should be considered for clinical trials. And so for the consideration of clinical trials, I think it's very important to repeat the entire mutational profile. Why does it need to be repeated? Well, we know that the genesis of acute myeloid leukemia is a multi-stage process with mutations occurring often in sequence, resulting in the phenotype of acute myeloid leukemia. When the patient achieves a remission, some of those clones that have developed may go into remission, but others may persist and generate the relapse, or new clones may pop up. And so the mutational profile at relapse may not be identical to that at initial presentation. In fact, for FLT3, it is estimated that about 5% of the time, a patient who is positive for a FLT3 mutation at diagnosis will be negative at relapse, and vice versa. If they were negative at diagnosis, they may become positive at the time of relapse.